A benign trigger, a slight change in temperature, a sudden intake of breath, a brief moment of exertion, causes the chest to tighten. The heart accelerates. The body prepares for a threat that does not exist. Panic disorder functions as a catastrophic misinterpretation of normal autonomic arousal. This mechanism is described by Stampler's integrated model. A minor shift in heart rate becomes a conditioned interoceptive stimulus. The brain registers a normal physical fluctuation as an immediate threat, creating a closed loop that amplifies the arousal into a full-blown panic state. To treat the disorder, clinicians must break this cycle. The established method is interoceptive exposure. In a standard cognitive behavioral therapy setting, a clinician induces these physical sensations artificially. Patients are asked to hyperventilate, breathe through a narrow straw, or spin in a desk chair. These procedures reliably trigger hyperarousal. They are also highly aversive. A substantial portion of patients refuse to tolerate the discomfort and drop out of treatment before the exposure can work. This leaves psychiatry with a structural problem. The only proven way to cure the fear of physiological hyperarousal is to induce it, yet our primary tools actively drive patients away. A 2026 clinical trial from the University of São Paulo was designed specifically to bypass this barrier. This is the trial's consort flow diagram. It tracks a highly specific demographic, 102 sedentary adults diagnosed with panic disorder, all of whom had been free of pharmacological treatment for at least 12 weeks. The researchers split this cohort. The experimental group received interoceptive exposure through a brief intermittent intense exercise protocol, entirely replacing office-based hyperventilation. The control group received Jacobson's progressive muscular relaxation training. This control group represents the prevailing clinical heuristic. When dealing with highly anxious, panicked patients, the intuitive response is to teach them physiological downregulation, how to calm their bodies. The experimental exercise protocol takes the exact opposite approach. It induces tachycardia, heavy breathing, and sweating. It mimics the somatic symptoms of a panic attack, but places those sensations within a safe, health-promoting context. By tracking these opposing methods, the trial tests a clear hypothesis. The clinical instinct to relax a panic patient fails them in the long term. The intense exercise protocol ran for 12 weeks. Patients completed 30-minute supervised sessions that consisted of a moderate baseline walk, interrupted by 6 sudden, high-intensity 30-second sprint bursts. The relaxation control group attended 45-minute sessions, dedicated entirely to deep breathing and systematically tensing and releasing 9 distinct muscle groups. Researchers measured efficacy using the observer-rated panic agoraphobia scale, a standardized metric for symptom severity. This graph plots panic agoraphobia scale scores. From baseline to week 6, both the green exercise line and red relaxation line slope downward. At week 12, the trajectories split. The exercise score drops to 14.9, while relaxation stalls at 23.1. This divergence results in a statistically robust interaction. The active physical exposure physically separates from the relaxation training. If we stop reading the data here, both treatments appear viable. Both cohorts exhibited lower severity scores at week 12 than they did at baseline. But short-term symptomatic relief is an incomplete metric. The true efficacy of a psychiatric intervention is measured by what happens to the patient's threat response after the clinical therapy stops. The trial included a 24-week follow-up assessment. For 3 months following the 12-week endpoint, patients received 0 clinical intervention. To determine if either treatment drove patients into actual remission, researchers tracked the raw frequency and intensity of panic attacks occurring in daily life. This chart plots panic attack frequency and intensity. Between week 12 and the follow-up, the relaxation group's red lines form a V-shape, showing a rebound. Conversely, the exercise group's green lines remain flat, suppressing attacks to a near-zero average. Relaxation training provides temporary autonomic masking. Because it actively avoids hyperarousal, the underlying catastrophic appraisals of a fast heart rate or tight chest remain intact when the patient encounters those sensations in the real world. The exercise group spent weeks repeatedly surviving tachycardia and hyperventilation on a treadmill. This forced their brains to decouple those specific physical sensations from the concept of an impending threat. This process is durable fear extinction. achieved through context-shifted interoceptive exposure. Treating panic requires rewriting deep interoceptive threat learning. Teaching a patient to breathe deeply and relax their muscles simply cannot perform that neurological task. The success of the exercise cohort presents a physiological paradox. If these were sedentary adults diagnosed with panic disorder, why didn't the intense 30-second sprints trigger massive panic attacks right there on the treadmill? According to the suffocation false alarm model, hyperventilation typically triggers panic because it rapidly exhales carbon dioxide, altering blood pH and signaling the brain that suffocation is imminent. But high-intensity exercise creates a metabolic offset. Rapid breathing causes respiratory alkalosis, attempting to push blood pH up. Simultaneously, extreme muscular exertion generates metabolic acidosis, pushing blood pH down. The two forces neutralize each other. This chemical counterbalance prevents the panicogenic pH shift, allowing the patient to experience extreme cardiovascular hyperarousal safely. Successfully navigating this hyperarousal also generated systemic downstream effects, visible in the Hamilton Depression Rating Scale data. This chart tracks anxiety and depression scores. Following the dashed lines to the final follow-up marker, the depression score for the exercise group continues to drop, while the relaxation group worsens. Resolving panic via intense physical exertion drives a long-term reduction in comorbid depressive symptoms, a result relaxation training fails to produce. This brings us back to the logistical barrier established at the start. Standard office-based exposure therapy fails because patients refuse to endure it. In this trial, out of the initial exercise cohort, the dropout rate was exceptionally low. Only 3 participants discontinued the protocol over the entire 12 weeks. Recontextualizing severe physiological stress as physical fitness removes the clinical stigma. It bypasses the raw aversion patients feel toward breathing through straws or spinning in office chairs. Furthermore, this new exercise protocol is also highly scalable. It does not require a highly specialized psychotherapist to administer. It can be monitored by general health or sports professionals using standard equipment. The prevailing clinical instinct to soothe and relax panic disorder patients is empirically flawed. Structured physical exertion actually provides clinicians with a much more precise, highly calibratable dosage of interoceptive exposure. To achieve durable remission in panic disorder, a clinician must not guide a patient away from physiological hyperarousal, but systematically straight through it.